Very good morning to everyone. Thank you for taking this Saturday morning time out of your weekend to attend our lecture. Okay, so I'm going to introduce you to our distinguished speaker, Prof. Dhanpat Jain. He is currently a professor of pathology and internal medicine at the section of digestive diseases at Yale School of Medicine. He graduated from Mysore Medical College, Mysore, India, and subsequently received his MD in pathology from the PGIMR in India. He then completed his anatomic pathology residency and fellowship in gastrointestinal pathology at Yale University School of Medicine, where he subsequently continued as faculty at the same institute. Dr. Jain is a very well-known person in the field of GI and liver pathology, having published over 200 articles, many book chapters, books, and reviews. He has delivered numerous lectures and participated in many courses at both national and international levels. He is on editorial boards for many high-impact journals, both in GI and liver disorders. His areas of expertise include motility disorders of the GI tract, liver fibrosis, metabolic liver diseases, liver neoplasms, and gastrointestinal lymphomas. I would like to welcome Prof. Dhanpat Jain to deliver his lecture entitled Approach to Challenging Motility Disorders of the GI Tract. Prof. Dhanpat Jain.
Thank you, Pavitra, for that very nice introduction. Good morning to everyone in Malaysia and that part of the world. And good afternoon or evening to rest of the people from different time zones who might be attending. It is a great pleasure to be speaking at this forum. This is my first time interacting with the pathologists from Malaysia. So I'm very delighted to be talking to you and presenting this lecture. This topic of neuromuscular disorders of the GI tract is very dear to me, but it also remains a very complex and challenging area of GI pathology. And this is for many reasons. The pathophysiology of many of these disorders is poorly understood. And many of these diseases do not have any specific diagnostic or a very specific histopathologic finding that one can rely on to make a diagnosis. And as you know, if you don't have any specific features that help you in making a diagnosis, that can become very frustrating. So this is frustrating not only for pathologists, but for clinicians as well, because for them also making the diagnosis is challenging. Even the treatment of these conditions is very challenging. And these are equally frustrating for both clinicians and pathologists. And this is one of the reasons that many people don't take up this area of pathology as their area of interest or research. And hence, there are only very few experts in the world. I have been involved with this for now many years, and as there are not many people who are interested in this field, I tend to get cases in consultation from all across the globe, from as far east as Japan or Australia or other parts of the continent. So I have written about this in various books, and there's a lot more information available there. You can read in detail about many of these conditions and many of the specific things about these disorders, as well as some of the very rare diseases in those book chapters or reviews that I've written. But today, what I want to do in this session is give you a very simplified approach to the diagnosis of some of the common neuromuscular disorders that you might encounter. Now, you have to recognize that these are complex diseases, and workup of these conditions is not very easy. In fact, the proper workup of many of these disorders requires, from clinical perspective as well as from pathology perspective, highly specialized setting, infrastructure, and facilities. And some of these are available only in certain institutions or certain laboratories. But what I'm going to talk today is something that most of the common pathologists working in any setting can do and approach these disorders from a clinical and practical perspective. And I'm not going to try to cover each and everything that is in the neuromuscular disease category in the GI tract, but focus on certain things that are probably more common and remain challenging for the pathologists. So I'll talk about some of the things that are common in different sites in the GI tract, esophagus. For example, achalasia is something that many people might encounter in their practice, gastroparesis in stomach. And in small and large bowel, I'll focus most of my attention towards chronic idiopathic intestinal pseudoobstruction. I recognize that Hirschsprung's disease is a very common issue, and probably among everything else, that is probably the commonest thing. I've not included that in my talk today because that by itself is completely independent talk and requires a lot of time and attention. So we'll talk about these conditions, and I'll use certain cases to illustrate various practical issues and how do you approach those things. So similar to any other disease that you deal with, the approach to motility disorders in the GI tract is not very different. You always start with good clinical history. However, I have to say that the clinical history in this setting becomes really, really very important. And as you will see through my discussion and some of the cases that I illustrate, the clinical history is many times not obvious. And you may have to take an extra effort to find out the clinical details, ask about various investigations, particularly regarding various investigations that might have been done, especially with regards to the motility issues of the patient. So in this area, I think the clinical history plays a very, very important role, and one has to be very diligent in making sure they have got all the necessary details by either reviewing the medical charts or asking the clinician. One may encounter a variety of specimens in clinical practice to evaluate motility disorders. But one has to understand the neuromuscular apparatus of the GI tract is largely composed of the muscular layers and neural networks, which are in the submucosa and the muscularis propria. Mucosal biopsies are largely useless from the purpose of diagnosis of motility disorders. And whenever they're performed, they're actually performed to exclude other conditions. And in motility disorders, most of the times, either they show nothing or show only non-specific changes that are diagnostically not very useful. So for making a diagnosis, either you require a full thickness biopsy or examination of resection specimens. Like any other pathologic examination, good gross examination is a key. You have to have a systematic evaluation of the histology. In this particular context, evaluating the various components of the neuromuscular apparatus in a systematic way is very important. And then given, in given settings, you may have to use various special stains, either histochemical stains or immunohistochemical stains. There is a role for electron microscopy, although I will show you that it is useful only in very select conditions, and in most of the cases, you really don't need it. Molecular and genetic testing, like everything else, is evolving rapidly. As you will see, it has a role in certain settings, and I anticipated in future the role for molecular genetic testing in these disorders is only going to grow in and become more and more critical. So having said that, let's start looking at certain cases, and through those cases we will try to see what are the practical issues and what are the challenges with some of these conditions and how to approach them in your clinical practice. So this case is of a 60-year-old female who had long-standing dysphagia to solid food and had intermittent vomiting of foul-smelling luminal contents. The imaging and barium swallow showed marked esophageal dilatation with narrowing of the distal esophagus. And with this history, I think anybody can think that the diagnosis is very likely achalasia, and the differential diagnosis would be so-called pseudoachalasia or secondary achalasia. So in this particular patient, at certain stage, because of end stage of the disease and no response to therapy, esophagectomy was performed. So briefly about achalasia and pseudoachalasia, because these are the two main conditions that you have to consider in this setting. Achalasia literally means failure to relax. This is a rare motor disorder which is characterized by the failure of the lower esophageal sphincter to relax during swallowing. Typically occurs in individuals over 60 years of age, but it can occur in children, particularly in certain syndromic conditions with no gender predilection. It is a disease which predominantly affects Caucasians throughout the world. And the typical history is of long-standing dysphagia to solids and liquids with repeated vomiting, chest pain, and heartburn. During endoscopy, the endoscope cannot be passed beyond the lower esophageal sphincter, but with little pressure, this lower esophageal sphincter opens up, and the endoscope can be pushed through it, or after use of amyl nitrate, which also allows this relaxation of the lower esophageal sphincter. And this is an important characteristic that helps clinically to distinguish between an achalasia or pseudoachalasia. The barium or other imaging studies will show in classic cases a markedly dilated esophagus with a very narrow beak-like deformity of the distal esophagus. Manometry shows reduced and abnormal peristalsis with increased intraluminal pressure and a failure of the lower esophageal sphincter to relax. Now, the pathology can vary depending on the stage of the disease. In the early stages of disease, which we rarely ever get to see in practice, one can see presence of ganglion cells in the neuronal plexus with inflammatory changes. However, as the disease progresses, the ganglion cells disappear. And by the time we see it or a clinical diagnosis is made, the ganglion cells are markedly decreased, and at the end stage, they are virtually absent in the distal esophagus. In this condition, mucosal biopsies are completely useless to make the diagnosis, and when they're performed, they are largely to exclude other conditions or for surveillance for malignancy. And while a variety of other treatments are available, end-stage disease often results in surgical resection. In comparison, pseudoachalasia has many of the features of achalasia with certain differences. And it's better called pseudoachalasia rather than secondary achalasia, which is also a term that is used in the literature, largely because many of the features, while they mimic achalasia, there are many differences that are kind of very distinct. And of all the things mentioned here, probably Chagas disease is the one which is best qualified as a secondary achalasia, because that also is associated with marked neuronal loss. Pseudoachalasia is even more rare. Actually, it comprises less than 4% of all cases that present with achalasia-like manifestations. And the etiologies for pseudoachalasia are highly varied, but most common cause is malignancy, which accounts for more than 70% of cases. And here, it is mostly the adenocarcinomas of the gastroesophageal junction that result in pseudoachalasia. However, a variety of tumors with paraneoplastic manifestation, certain infections, particularly Chagas disease, or strictures resulting from reflux or other surgeries in this area can result in pseudoachalasia. It has also been described with many systemic disorders listed here, like sarcoidosis, amyloidosis, neurofibromatosis, leiomyomatosis, or juvenile Sjogren syndrome, and extremely rarely with the familial glucocorticoid deficiency. These are extremely rare sort of presentations with pseudoachalasia. The clinical manifestations and patient symptomatology are largely very similar to achalasia. However, generally the duration of the symptoms tends to be shorter. And most of the time, the underlying disease that resulted in achalasia-like symptoms, either the malignancy or a systemic disease, is known or sometimes diagnosed during the investigations. As I mentioned, one of the sort of typical features of achalasia is that despite the narrowing or difficulty in passing the endoscope through the lower esophageal sphincter, it can be passed with little pressure, but with pseudoachalasia, the endoscope cannot be passed through the lower esophageal with that ease. It is either impossible or it's passed with a lot of difficulty. And pathologically, unlike achalasia, where this near total to total loss of ganglion cells, in most cases of achalasia, the ganglia and neurons are present, except for maybe Chagas disease or some post-inflammatory conditions, post-infectious conditions. And here, the treatment and prognosis of the pseudoachalasia depends on the primary disease that led to the pseudoachalasia. So in this particular patient, the esophagectomy was performed, as I mentioned, and here is the specimen. And as you can see, the esophagus is markedly dilated, and the distal part of the esophagus is narrow, as was already evident during the imaging studies. And this is classic of achalasia. The mucosa looks a little bit thickened with very prominent folds. Often one can see luminant contents or foul-smelling food sticking in this area. This has been cleaned, so you don't see that. Histologically, the characteristic finding, as I mentioned, is almost total loss of ganglion cells in the neuronal plexus. You can see sparse inflammatory cells in this area or in higher magnification, but look carefully, there are no ganglion cells. At the end stage of disease, even if you find few ganglion cells, it is unlikely to be achalasia. It is more likely pseudoachalasia due to some other cause. So in this particular case, the diagnosis is achalasia cardia. Let's look at another case. Here, I'm not going to go through the entire history. It's virtually identical to the first case that I showed you. And the diagnosis was, again, achalasia or pseudoachalasia. And the esophagectomy specimen is shown here. It also shows dilatation of the proximal esophagus with narrowing of the distal part, fairly similar, but maybe the dilatation of the proximal stomach, proximal esophagus is less marked than the previous example. Nonetheless, fairly similar in gross appearance. The part of the stomach here looks a little bit odd because I think you will find out there was something else done to this patient. Histologically, this is the area of the GE junction. You can see otherwise it all looks fine. There's probably a suture material in this area. And close examination of the myenteric plexus revealed presence of ganglion cells in the nerve plexus in different areas. The number of ganglion cells probably were reduced in some areas, but they were certainly easily identified and present. So with that, I think, as I mentioned, a diagnosis of achalasia cardia becomes unlikely, and one has to consider pseudoachalasia. So in this case, once we recognized that and looked into the history of this patient, the patient did have a history of long-standing reflux, which was treated with Nissen fundoplication, and the patient had developed a stricture. So that makes it very clear that this was actually a case of post-surgical stricture and a pseudoachalasia, not true achalasia. So again, as I mentioned earlier, the clinical history sometimes is very important, and one may have to sometimes go to extra distance to find the critical clinical information. So now let's move on to next case. This is a case of the stomach. The patient had long-standing history of intermittent and intractable vomiting for many years. The patient had a known history of type 2 diabetes, and clinical investigation revealed marked dilatation of the stomach with reduced peristalsis with delayed emptying. On endoscopy, chronic ulcer in the antrum was identified. However, the pylorus was patent. The clinical diagnosis was diabetic gastroparesis, and because of non-healing ulcer, the patient underwent a gastrectomy. This is not a common scenario, but however, this is what happened in this particular patient. So in this setting, the differential diagnosis when you're markedly dilated or distended stomach is gastroparesis, which could be idiopathic or associated with the other systemic disorders like diabetes. Hollow visceral myopathies come in the differential diagnosis, and dilatation of the stomach due to obstruction, usually at the pyloric canal, is also in a differential diagnosis, which at least in this particular case was easily excluded because the endoscopy showed patent pylorus, and the other conditions are mainly the differential diagnosis. So what is gastroparesis? Well, it's paralysis of the stomach, which results in delayed emptying of the stomach with reduced peristalsis. As I mentioned, it could be either idiopathic or secondary. Diabetes being the most common association in that setting. Rarely it has been described in association in cirrhosis as well. The pathology is highly variable. Many cases have absolutely no significant findings and appear normal. However, in other cases, you may see a variety of changes, and these are thought to be non-specific and possibly secondary in nature. And these include many things. Most importantly and most commonly, one can find cytoplasmic inclusions in the smooth muscle that are negative on PS staining. One can see reduced number of ganglia in the nerve plexus. There could be some inflammation around the nerve plexus. And if you look for the interstitial cells of Cajal, which are the pacemaker cells, you can identify either reduced numbers of interstitial cells or loss of their dendritic processes. Surgical resection is not the treatment for this case, these cases, and if it is performed, it is largely for other reasons. And in this particular case, as I mentioned, it was done for the non-healing antral ulcer. So this is the specimen from this particular patient, which shows hugely dilated stomach. Opened up stomach shows normal mucosal folds. Here in this area, one can see an ulcer, which was the reason for which this gastrectomy was performed in this patient. And histologically, this is a low magnification to show you the mucosa, which was largely unremarkable, except for the ulcer, which was fairly non-specific in histologic, features. Rest of the things look more or less normal on low power. However, on closer look, one could see these cytoplasmic inclusions in the smooth muscle in this particular case, which I mentioned are sometimes seen, but are certainly not specific for this condition or pathognomonic of gastroparesis. The ganglion cells were present. However, in some areas, one could see lymphomononuclear inflammation around the ganglion cells and the neural plexuses, which again is a non-specific finding, but seen in a subset of these patients. Other areas, again, showing presence of the ganglion cells and sparse inflammation in the wall. This is the c-kit stain to highlight the interstitial cells of Cajal, which you can see are present here. I'll show you later in some other slides the morphology of these interstitial cells of Cajal, which typically have a lot of dendritic processes. Here in this particular situation, you see them, you can identify them. These are all the interstitial cells of Cajal, but they don't show their normal dendritic processes, which is, again, recognized in this setting. So in this case, the diagnosis was fairly easy because clinically the diagnosis of gastroparesis was already made, and the patient had a history of diabetes, and we had some of these histologic changes that go along with gastroparesis as well. So now let's move on to the intestines. Shown here with this next case, which was of a 40-year-old female who had a long-standing history of constipation over 20 years. She had some autoimmune kind of features. Initially, she was found to be ANA positive, but on repeat testing, that turned out to be negative. She was positive for HLA-B27. She had erythema nodosum, uveitis, iritis, and arthritis as other systemic manifestations. Because of this bowel dysmotility, she was treated with prokinetics, which showed some response initially, but afterwards, she had very marked distension in the bowel with absolutely no passage of stools, and it became severe enough that she had to undergo total colectomy eventually. On investigation, she did not reveal any family history of any motility diseases. As I mentioned, because of the severe dysmotility, she had marked dilatation of the large bowel, which was excluding the rectum. On investigation, she was also found to have dilatation and enlargement of the urinary bladder, but other hollow viscera like gallbladder and other parts of the GI tract appeared normal at that time. Because of her symptoms, initially she was diagnosed with Crohn's disease, but soon they recognized that this was not Crohn's disease, and a diagnosis of intestinal pseudo-obstruction was made. However, it was unclear whether this was primary or secondary intestinal pseudo-obstruction. As I mentioned, this resulted eventually in total colectomy, and we'll come to the specimen later on. So This brings us to the next set of disorders, which represent the intestinal pseudo-obstruction type of disorders. And as the name suggests, these are conditions that manifest like obstruction but don't have obstruction. So the definition is that these are a group of propulsive disorders in which typical signs and symptoms of intestinal obstructions occur in the absence of a typical mechanical lesion. These can be both acute or chronic. And acute conditions, again, we don't deal with them much, and they are represented by either paralytic ileus or Ogovo's syndrome, and they're something that we don't encounter as pathologists. So I'm not going to talk about that. But the one which remains challenging for us, and we do see specimens from chronic cases, and these can be either primary or so-called idiopathic, where there's no obvious disease association is found, or this could be secondary, where the dysmotility is clearly associated with either systemic disease or a known cause. So the variety of causes that can result in pseudo-obstruction are listed here, and these are all secondary forms of intestinal pseudo-obstruction. Variety of systemic disorders, as listed here, can result in chronic intestinal pseudo-obstruction. Variety of endocrine and metabolic disorders, particularly diabetes, can result in chronic intestinal pseudo-obstruction. Infiltrative disorders like amyloidosis or lymphoid infiltration or eosinophilic infiltrations in the neuromuscular apparatus can result in pseudo-obstruction. Certain paraneoplastic syndrome, particularly small cell carcinoma, can manifest as intestinal pseudo-obstruction. Infections, particularly Chagas disease, can present with extensive dilatation of hollow viscera, resulting in megacolon or mega, esophagus, and is seen in certain endemic areas where you have this infection that is prevalent. However, in other areas, you rarely see these conditions. Some of the infections listed here, like herpes, cytomegalovirus, EB virus, can also result in intestinal pseudo-obstruction, but these are temporary. And as the infection goes away, many times they will heal on their own, or sometimes after some time. JC virus has also been implicated, but I think now most people believe that is probably not bona fide cause of a intestinal pseudo-obstruction. Variety of medications have been associated, and again, one has to carefully look in the history whenever you are dealing with the case of chronic intestinal pseudo-obstruction to make sure this is not a manifestation of some of these medications. And there are a variety of other things listed here, of which I'll show you a couple of examples as well. When you have excluded the secondary causes, then what is left is what we refer to as primary or idiopathic chronic intestinal pseudo-obstruction, which can result from abnormalities in any component of the neuromuscular apparatus of the GI tract. And as you know, the components of the intestinal neuromuscular apparatus include the muscle layer, the nerve plexuses, the pacemaker cells, which are called the interstitial cells of Cajal, and various neurohormonal peptides that can regulate or control the GI motility. So abnormalities in any of the components of these this neuromuscular apparatus can result in intestinal pseudo-obstruction. And under the various muscle disorders, there are familial forms and there are sporadic forms. Same with neuropathic forms. There are familial and sporadic forms. Hirschsprung's disease is a special category in this one, which is a neuropathic form. And as I said, that we are not going to talk about this today, but this remains one of the commonest and the most encountered problematic thing in practice, and deserves a full lecture on this topic. Disorders of the interstitial cells of Cajal can be primary or sometimes associated with other forms of intestinal pseudo-obstruction. Disorders of neurohormonal peptides are very uncommon and very difficult to study. Okay. So diagnosis of chronic intestinal pseudo-obstruction initially is made with the clinical workup that requires putting together the history with the findings on examination and imaging as well as manometry. Main purpose of all the investigation is to show that there is an obstruction, but there's no, or the features are like obstruction, but there's no mechanical or secondary cause that can be identified. Eventually, many of these disorders require a full thickness biopsy or resection to establish the diagnosis. And that's where we play a role. Clinically, as I mentioned, these are very difficult to treat and challenging for the clinicians. While a variety of prokinetic things are available, they don't work very well in many conditions. Many times the clinical treatments is limited to just supportive care and providing nutritional support. And many of the cases that are refractory to all sort of treatment may have to undergo radical surgery to remove the affected segment of the GI tract. So now I'll briefly go over how do you work up all these cases before going to this particular patient that I described. And some of the basic things I already mentioned, but I'll go and highlight many of the things and show you what are the important things that you look and what are the other findings that you can see. So as I mentioned, the pathologic examination of these things starts with gross examination. You have to do a very good gross examination, then go to microscopy, look at the H&E slides, then decide to do stains based on the case. The common stains that are used in this setting are the trichrome stain and PS stain. I'll show you how they're important and why they're important. Variety of immunohistochemical stains are needed in certain settings as listed here. To highlight the neuronal plexus, one can use S100 or PGP 9.5. You can use various neuronal markers to highlight the ganglion cells. The smooth muscle marker SMA and desmin also are useful in certain conditions. The stains to highlight the interstitial cells of Cajal, c-KIT or DOG1 also play an important role. Immunohistochemical stains for various neurohormonal peptides are not easily available. We don't have them either. And they're available in only few research laboratories or specialized centers, and have a very limited role in at least most of the common conditions that we see. Electron microscopy can be useful in certain settings, and I'll show you examples of that. And as I mentioned, the molecular and genetic tests are increasingly playing an important part in the diagnostic workup. So when you look at these specimens grossly, you look at whether the segment is dilated or narrow, or it has unusual angulated or kinking that could be a cause for the obstruction. You look at the thickness of the bowel wall. Is it thick or thin? You can see a variety of things. Sometimes it's completely normal. Carefully look for the layers of the GI tract. As you know, in the muscularis propria, there are two layers, the circular layer or the longitudinal layer, but there are certain conditions where you can get extra layers of the GI tract. And those are difficult to identify in gross examination, more easily seen on microscopy, but sometimes you can see them on gross as well. You look for adhesions, strictures, or masses that will make this not an pseudo-obstruction, but obstruction due to mechanical causes. And sometimes these are not easily obvious to the clinicians. And we as pathologists may be able to either confirm the clinical diagnosis or sometimes identify this as the cause for the obstruction. Look for diverticular. Sometimes they actually point towards motility problems, or sometimes they may tell you that this disease is not a problem of the neuromuscular apparatus. So when you start looking at the histology, you can see all the layers of the GI tract, the mucosa, the submucosa, the muscle layer, and the neuronal plexus. You can start looking at them systematically from one side to another side and look at each part carefully, looking for various findings. For example, when you look at the mucosa, in many of the cases of motility disorders, the mucosa may be completely normal. In some cases, you may see mild changes of inflammation or some crypt distortion, and these are largely due to long-standing stagnation, stagnant food or stasis of various other things, and are completely non-specific. If you find significant mucosal pathology, you have to consider other diagnoses. The common finding in many of these cases is melanosis of the intestines, because many of these patients are taking laxatives to overcome the constipation. And as you know, the melanosis is associated with the chronic laxative use. So mucosal features are largely to exclude other diseases and are generally non-contributory. You look at the submucosa. In submucosa, you can see a variety of things that may explain the pseudo-obstruction or sometimes stricture, like fibrosis, for example. There are certain other things which can result in intestinal pseudo-obstruction. For example, presence of amyloid. Amyloid can get deposited in any layer of the GI tract, including submucosa, muscle layer, or around nerve plexuses, and it should be visualized on H&E stain and confirmed with the special stain like Congo red. People have also kind of shown that some disorders are characterized by increased number of mast cells in the submucosa. This is something that I have not diagnosed and not seen, and this remains slightly controversial, but it's certainly something that you can look for, and this can be easily highlighted with special stains like c-KIT or mast cell tryptase. After submucosa, then we move on to the muscle layers. When you look at the muscle layers, you look at the thickness, you look at the individual layers to see if they're normal in thickness or there's an preferential thickening or thinness of any of the layers or disappearance of the layers. For example, here you can see marked thickening of the both inner circular and outer longitudinal layer of the muscle. And in certain condition, you can see preferential disappearance of in one of the layers. You look at the higher magnification of the morphology of the smooth muscle cells. And as you can see here, in this particular example, there is a marked variation in the size and shape of these muscle fibers. There's variation of the nuclei. There is a variation in the staining of the cytoplasm of the smooth muscle cells. The nuclei also appear very hyperchromatic. And if you look at the interstitium, there is increased matrix in between, which is largely fibrosis between the smooth muscle cells. So there are a variety of findings that can be seen in the muscle layer. In many conditions, they're completely normal as well. One important thing to look for is interstitial fibrosis, which is suggestive of various myopathies, and that may require a trichrome stain to appreciate many times, especially when it's a very delicate interstitial fibrosis. It may not be obvious on H&E stains, and a trichrome stain is very useful in that setting. This is one example of complete disappearance of the outer longitudinal layer of the muscle, as shown here. This is the inner circular layer. You can see the neuronal plexus right here. This was a case of scleroderma. You can see some of the vascular changes associated with scleroderma in one of the vessels here. And in scleroderma, you can have intestinal pseudo-obstruction. So identifying the change in the muscle can be very, very helpful. In this particular case, we also looked at the interstitial cells of Cajal, which actually disappear in primary visceral myopathies, which is in the differential diagnosis. But in cases of scleroderma, usually they are preserved despite the loss of the muscular layers. This is another example of scleroderma showing you abrupt kind of disappearance of the outer longitudinal layer of the muscle. In this area, probably a little bit thin and about to kind of disappear. And in this area, there is complete disappearance of the outer longitudinal layer. It is said that generally outer longitudinal layer is the characteristic of change in cases of primary visceral myopathies, but we have seen this happening in case of scleroderma as well. And we have seen the reverse in some cases of visceral myopathies. Actually, it is the inner circular layer that is affected more than the outer longitudinal layer. As I mentioned, in some cases, you may have extra layer of muscle, and that can be more easily recognized on microscopy. And some of these are congenital and inherited disorders, as shown here. This was reported by Dr. Raj Kapoor. And this is an extremely rare condition where you can find an extra layer of smooth muscle associated with FLNA mutations, which is an excellent condition resulting in the intestinal pseudo-obstruction. You look at the morphology of the muscle cells, you look at the cytoplasm, you look for inclusions or any pigment. For example, in this particular case, you can see deposition of dark pigment, which is highlighted in higher magnification. And this is lipofuction pigment. And this is a condition which is called brown bowel syndrome due to accumulation of this pigment. And it's typically associated with malnutrition and attributed to vitamin E deficiency. You look at the muscle layers for various inflammatory cells. And in this particular example, you see this is a mucosa, looks fine. This is the inner circular layer, looks fine. But in the outer longitudinal layer, there are inflammatory cells. And if you look at higher magnification, they are mostly eosinophils. And this is another example to show infiltration of the muscle layer by eosinophils. And if you remember, in eosinophilic gastroenteritis, there are different forms. There are certain forms which are the deep forms of eosinophilic gastroenteritis, where only the deeper layer, like the muscle layer, is involved, and the mucosal biopsies may have nothing. And once you have a resection or full thickness biopsy, you can make this diagnosis. This is just to show you hyper of the case showing eosinophils infiltrating the muscle. Similar to eosinophils, some cases have infiltration by lymphocytic cells, and this has been associated with autoimmune enteric leiomyositis, again a very rare condition resulting in intestinal pseudo-obstruction. When you look at the smooth muscle, some of the cases may show abnormalities only on special staining. So this is an example where SMA staining shows deficient smooth muscle actin in the inner layer of the muscular layer of the intestine. This is again a finding that has been described in certain forms of intestinal pseudo-obstruction and will require immunostaining. Here, I would just give a word of caution that this finding can be seen in the terminal ileum in many patients who do not have any dysmotility and is a normal variation. So before making a diagnosis of alpha smooth muscle actin associated interstitial obstruction, make sure this is a finding not restricted only to terminal ileum, but is a more diffuse finding. Another condition that has been described with the use of smooth muscle actin is this inclusion body associated interstitial pseudo obstruction, where these inclusion bodies are highlighted either with an SMA immunostain or even with a PS stain. And again, these are important stains in the workup of interstitial pseudo obstruction, and can be very helpful in identifying these particular kinds of myopathies. However, one should be again careful. There are many other artifacts that can mimic these muscle inclusions. I'm showing here one kind of an artifact where these smooth muscle cells have this kind of hyaline and glassy kind of an inclusion. And when you see this thing, often this is present in extensive stretches of the smooth muscle in certain areas of the section or part of the bowel, whereas remaining part of the bowel will appear normal. I've seen this kind of artifact in many of the cases without any intestinal pseudo obstruction. So before attributing these as cytoplasmic inclusion, one has to make sure this is not an artifact. So once you have looked at the muscle, then you move on to the neuronal plexus. And these are present in the submucosa as shown here, or between the muscle layer, which is the myenteric plexus, which comprises of ganglion cells surrounded by glial elements and nerve fibers. And these are very easily identified on H&E in all cases. When you look at these things, you look for either complete absence of ganglion cells or increased numbers or decreased number of ganglion cells. Here is a case where you see markedly increased number of ganglion cells, and this has been called hyperganglionosis, or otherwise also called as intestinal neuronal dysplasia, a rare and a controversial entity. And for this diagnosis, you require more than 8 neuronal cells in each ganglia, and such ganglia should constitute more than 20% of all the ganglia. So you will see case reports of this occurs typically in the pediatric age group, and is usually a differential diagnosis of Hirschsprung's disease. This is a case showing very sparse ganglia. This is an example of hypoganglionosis. Again, a controversial kind of entity, difficult diagnosis to make, and the criteria requires that you have one or less than one ganglion per millimeter length of the bowel, and this requires careful sampling and identification of the ganglion cells. Sometimes requires good neuronal markers as well. When you're looking at the ganglia, also look at the other components in the ganglia, like the glial cells or presence of inflammatory cells. In this example, you see a lot of eosinophils infiltrating into the ganglia, and this is something that has been associated with intestinal pseudo obstruction, and this is referred to as eosinophilic myenteric ganglionitis. Something that sometimes respond to steroids and can be self-limiting. Other thing that you can sometimes identify is presence of ganglia in the lamina propria. Normally, as you know, ganglion cells are not seen in the lamina propria. However, they can be occasionally seen, and if you see them focally or a few numbers, probably it has very limited clinical significance, especially if they are not associated with polyps or polypoid lesions. However, if you see diffusely aberrant ganglia in the lamina propria, it could be a marker of Men's syndromes, and in that condition, sometimes patients may have intestinal dysmotility as well. In ganglia, you look at the morphology of the neuronal cells, you look at the nuclei, and some of the cases have been described that have very prominent CMV inclusion-like nucleoli, which are negative on CMV stain, but represent some peculiar neurofilament aggregations within the nuclei, and have been associated with presence of or presentation with intestinal pseudo-obstruction. This is also a very, very rare kind of condition. I haven't seen any cases. This is from this particular publication. And in this setting, once you identify, you exclude CMV infection, and sometimes electron microscopy can help you to identify those abnormal filaments. Once you have looked at neuronal cells, you look at the presence of plexus, which can be highlighted with various stains that highlight the axons like S100 or PGP 9.5. Most of the time, you can see the neuronal plexus very easily. However, the stains can highlight sometimes subtle changes, and particularly when the neural plexus are atrophic or very, very markedly thinned out. This is another example to show you the S100 stain. And people, if you have not done S100 stain in GI tract, try out sometime. You'll be surprised to see how many nerve fibers are present in the muscle layers, and it can be striking, and this is normal. The other cell type that one needs to study in the neuromuscular apparatus are the interstitial cells of Cajal. These are dendritic cells that are called the pacemaker cells of the GI tract, and appear like this with the dendritic processes, and are typically aggregated around the myenteric plexus, particularly in the small bowel, and can only be identified with the help of special stains or electron microscopy. The special stains are now easily available, like c-KIT or DOG1, and they are kind of critical in helping to understand the morphology and distribution of interstitial cells of Cajal in clinical practice. While many cases associated with intestinal pseudo-obstruction that have myopathy or neuropathy, the interstitial cells of Cajal are either lost or less in number. Rarely they can be more, like shown here. Hypertrophy of the interstitial cells of Cajal, which appears like a band-like thing in between the two layers of the muscle, easily highlighted with the c-KIT stain. This is again a rare condition associated with either c-KIT mutations or sometime with neurofibromatosis type 1, where some of the patients may have intestinal dysmotility. BCL2 is a stain that is sometimes used to highlight the ganglion cells, and some people had described some cases of intestinal pseudo-obstruction with abnormal expression of BCL2. However, I think that has not stood the test of time, and in my experience, this is now completely useless, and I don't use it at all in the workup of intestinal motility disorders. A variety of neuronal markers can be very helpful, particularly in cases where you're dealing with the loss of ganglion cells or hypoganglionosis, and variety of markers are available, of which some of the more specific ones are the FOX2B and HUCD. However, calretin and BCL2 can also serve as a neural markers and more readily available in variety of labs. Again, they also play an important role in the workup of Hirschsprung's disease. Electron microscopy has also been used in the workup of intestinal pseudo-obstruction. but rarely is needed in current practice, because many of the things that were earlier described with the help of electron microscopy now can be diagnosed or identified with the help of special stains. In fact, earlier, all the visceral myopathies and problems with the interstitial cells of Cajal were studied with electron microscopy in the early 80s and 90s, but now c-kit stain has replaced electron microscopy for that purpose. However, still the electron microscopy can be sometimes useful in demonstrating various abnormalities in the smooth muscle or ganglion cells, or the interstitial cells or mitochondria, and confirming that there is some ultrastructural abnormalities, and in certain cases actually can help establish the diagnosis as well. This is one example where a diagnosis of lysosomal storage disease was established with the help of electron microscopy. However, again, in many cases, the clinical diagnosis is known, and the electron microscopy in this setting only demonstrates involvement of the neuromuscular apparatus in the presence of GI dysmotility. This is a case of Fabry's disease, where you can see this foamy histiocytes in the, the foamy change in the neuronal cells in the meningeal plexus. So I mentioned that the genetic and molecular tests are now increasingly being employed in the diagnosis of some of the disorders, particularly in children and in a variety of neonatal syndromes that are associated with the intestinal dysmotility, and they're all listed here. This is a busy slide. You probably can't read many of the things. The whole idea is to show that the number of genetic alterations that have been now associated with variety of intestinal disorders have increased, and many of these conditions now have been identified to present late or sometimes with milder manifestations in adults. And as we learn more and more about these disorders, I suspect that the role of molecular diagnosis or genetic diagnosis in these conditions is going to only increase. Currently, I think they are useful in separating some of the disorders that have very close resemblance, or sometimes in the familial settings. A word about the pediatric versus adult chronic intestinal pseudo-obstructions. Many things are similar, but there are some differences as well. The pediatric intestinal pseudo-obstructions tend to be predominantly primary, secondary being very uncommon, whereas in adults, the secondary forms are much more common. The neuropathies are common in both, but they're much more common in the pediatric group. Again, the clinical manifestations also slightly differ. Overall, the outcomes are poorer in the pediatric age group compared to the adults. These are all listed here. You can look at these details later on, or look up in the book. The key thing to remember is that there are certainly a lot of similarities, but there are many differences between the pediatric forms of chronic intestinal pseudo-obstruction cases. So, having given you an overview of how we work up these cases, how we examine the various components of the neuromuscular apparatus, what are the key things to look for, let's get back to the case. So this case had a total colectomy, and the large bowel was markedly dilated. Here you see the opened up bowel, and here is a normal large bowel for comparison to show how much dilated this case was. And this is what we refer to as megacolon. This particular colon showed many areas where the bowel was markedly thickened, but in some areas it was thin as well. Histologically, this showed thickening of both the inner and outer layers of the muscularis propria. Here you can see the presence of the neuronal plexus. The mucosa looks largely normal. On higher magnification, you can see the delicate interstitial fibrosis in the inner circular layer. If you look at the higher magnification, you can see changes in the muscle cells with variation in the size, variation in the staining intensity, more darker staining in some cells compared to others, cytoplasmic evacuation. All those are changes suggestive of degeneration in the muscle cells. And in many areas, the fibrosis has completely replaced this inner circular layer of the muscle. So all these features point towards a visceral myopathy. Special stains demonstrate presence of normal neuronal plexus. However, the marker for interstitial cells of Cajal c-KIT showed complete absence of all the interstitial cells in the muscle layer and around the plexus. This is a higher power to show you complete absence of interstitial cells of Cajal around the plexus and between the muscle cells. So in this case, we established a diagnosis of primary visceral myopathy. Moving on to next few cases, I think we are over time, right? We are already past.
Yes, Prof, but it's okay. Go, please
so
continue.
we have only just few more slides, so we are almost done.
Okay, all right.
So this is a case which was fairly similar to what I presented earlier. Clinical diagnosis again was possible visceral myopathy. A resection was done, which showed the features that were more or less similar to the previous case with thickening of the muscle layer and normal mucosa. However, closer examination of the case showed presence of diverticula. So presence of diverticula, and these are the acquired type of diverticula, generally suggests that the muscular apparatus is working fine, because to diverticular develop, you have to generate enough intraluminal pressure for this diverticular to form. So the neuromuscular apparatus probably is otherwise fine, and this was certainly not a case of primary visceral myopathy. However, the patient may have idiopathic chronic constipation in this case, which is a condition which probably represents a very heterogeneous group of disorder, which is somewhat similar to idiopathic, intestinal pseudo-obstruction, but probably a much more milder version of it. The changes seen in the various neuromuscular apparatus are similar to intestinal pseudo-obstruction cases, but again, highly variable, and in many cases, there are absolutely no changes seen. Of all the findings, probably reduced number of interstitial cells of Cajal is probably the most consistent finding, but is very difficult to study, and its diagnostic significance remains still questionable. So in this case, I think we could certainly say that it was not a form of hollow visceral myopathy or significant, muscular disorder, but very likely some form of chronic idiopathic constipation or something else. This is another case which was of GI dysmotility diagnosed in a child, and the child had many different symptoms. Most importantly, had extreme fatigue and body aches, had a history of recurrent infection that required hospitalization, many hospitalization, in fact. Sorry. The patient also had pancytopenia and eventually underwent near total colectomy with ileostomy. And later on, the patient had to be on TPN for life. However, the histology of these large ball and small ball were completely normal. Couldn't find any abnormality. And on trichrome stain or other stains, everything looked fine. The neuronal apparatus with presence of ganglia and neuronal plexus were all normal. There was nothing abnormal on histology. And that's not uncommon to see in our practice, that some of the cases that come up with clinical diagnosis of intestinal pseudo-obstruction have histologically no specific findings or sometimes no findings at all. However, in this case, there are a lot of other things going on clinically. We asked the clinicians about more history, and eventually we found out the patient actually had a diagnosis of mitochondrial complex 1 deficiency. So that kind of explained why there was severe muscular dysfunction in this particular patient. And the diagnosis finally in this particular case is mitochondrial myopathy, although histologically we could not make the diagnosis. So a word about mitochondrial myopathies, because this is something that one can encounter in a patient like this, where on pathology you may have absolutely no clue. So if you look at all mitochondrial disorders, GI dysmotility is seen in about 15% of all patients. And if you look at patients with chronic idiopathic pseudo-obstruction, mitochondrial disorders can be identified in just less than 20% of all patients. And in patients with intestinal pseudo-obstruction, where you cannot find any explanation, I think one should try to explore a possibility of a mitochondrial disorder with relevant investigations and genetic testing. This is something that sometimes will give you the diagnosis when other things have failed, and should be kept in the differential diagnosis. So just another case of mitochondrial myopathy, which is this particular syndrome, which is very rare. It is called familial neurogastrointestinal and encephalomyopathy, where you can see bowel dysmotility, and shown here is in this particular case, complete disappearance of the muscle layers. In this area, you see complete loss of longitudinal layer, and in this area, you see loss of both circular and longitudinal layers, leading to a diverticular formation. Here you see fibrosis in the outer longitudinal layer in this particular case, and this is to show that neuronal plexus are preserved but look atrophic, as highlighted with the S100 strain. In this particular area, the longitudinal muscle has completely disappeared. Also identified were ganglia cells, but they were reduced in numbers. This is an example of mitochondrial myopathy, where you had many different kind of findings. In mitochondrial disorders, you can see a range of disorders, a range of findings that can resemble myopathies or neuropathies, or as I showed you, can be completely normal. So you have to keep this in your differential diagnosis when dealing with intestinal pseudo-obstruction cases. This is just a summary slide to show you the kind of many primary changes that you can encounter with the cases that I showed you, with either achalasia, gastroparesis, or chronic intestinal pseudo-obstruction, or mitochondrial disorder, as I illustrated. Many of the associated changes are listed here. You don't have to read those things, but these are just for the sake of completion, and these are written in more details in the book. The question is, I showed you many different things that you do with such cases, how you work them up. You do all the special stains, and you look at all the critical things. The issue is how useful it is. How many times do you really get a diagnosis after this workup? And this was one study which analyzed 21 cases of chronic idiopathic intestinal pseudo-obstruction. And in this particular study, they could make a diagnosis purely based on histology in 62% of the cases, which represented myopathies, neuropathies, and mixed forms. Histologically, interestingly, 8 of the cases were normal. However, they showed abnormalities on special stains, as I illustrated in some of the cases, that either stains for interstitial cells of Cajal or SMA can highlight abnormalities which are not easily visualized on routine histology. So this was kind of also highlighted in the study, and it showed that actually if you work these cases up systematically with everything, you can come to a diagnosis in most of them. However, Having said that, I would say that in my practice, there are still a lot of cases where we come up with no specific findings or no specific diagnosis, and these do remain a very challenging group of disorders, which show wide range of changes, sometimes completely non-specific and difficult to interpret. In many cases, when you see findings, it remains unclear whether they are primary or secondary or specific or non-specific. And as I was telling you, that in many cases, the extensive workup comes out completely negative, and we cannot offer anything. So with that, I would like to say that these are certainly very complex and rare disorders, and they are exotic in some ways. Whenever you can come up with the diagnosis, or you are able to help the clinician, it looks like this beautiful flower. You're very happy. It looks very nice and satisfied. However, that's not always the case. So with that, I'd like to thank you all for your attention and listening to this talk. And we'll be happy to take any questions from this one.
Thank you, Prof, for a very, very informative lecture. It was too enthralling that we didn't want to stop you, even though we overshot time a little bit. So there are a few questions. So I'll start on the question. So how do we cross the achalasia resection specimens? Do we need to take continuous longitudinal sections from proximal to distal margin, as we do in Hirschsprung's cases?
So that's a very good question. The most important finding in cases of achalasia is in the distal, esophagus, near the GE junction, near the lower esophageal sphincter area. So that's the area that you need to sample well. And as I mentioned, that if your initial samples don't, show ganglion cells, you may have to sample well to make sure that there are no ganglion cells. But if you find ganglion cells, then at least this is not, primary achalasia. You really don't have to demonstrate the absence of ganglion cells proximally. However, we do take samples along various areas of the entire esophagus just to kind of study where the ganglion cell loss has started and is most extensive. But unlike what you do with the Hirschsprung's disease, where generally you will try to take a strip and try to define the transition zone and all those things, here that's not that critical.
Okay. Okay, thank you. Next one. Do you report the length of a ganglionic segment in achalasia report? Wondering if, you've answered.
So we just don't. I mean, there's no clinical significance to that. And I think just identifying loss of ganglion cells is good enough to make the diagnosis.
Okay. All right. Next question. In newborn babies that are suspected of Hirschsprung's disease, but we see presence of small ganglion cells and some calretinin positive nerve fibers in the mucosa, what other differentials should we consider for the dysmotility seen?
This is a good question. I know that I was not talking about Hirschsprung's disease, but Hirschsprung's disease will come up because this is the common problem, and there are several challenges in this area. So, once you see ganglion cells, no matter how many, you virtually rule out Hirschsprung's disease. Okay. The only thing we want is to make sure that you are not in the, what you can call, the dilated segment. You're in the right area that the biopsy has been, taken. And once you see ganglion cells, but if you see, either small ganglion cells, which are sometimes marker of immature ganglion cells, which can occur in premature individuals or premature kids, in those kids, sometimes they will mature and symptoms may disappear. So that's a sign of prematurity, and in that case, identifying them as ganglion cells can be problematic because they are small in size and may look like plasma cell or lymphocytes.
Yeah.
So in those cases, using a ganglion cell marker is very useful, and in such cases where you have presence of ganglion cells and some abnormal staining, either with calretinin or acetylcholinesterase, you have to consider intestinal neuronal dysplasia, hypoganglionosis, and there are other what are called the allied disorders of Hirschsprung's disease. And those need to be considered, and that remains a very, very challenging and controversial area. And I think overall, I think the emphasis is always on, at least if you've done excluded Hirschsprung's disease, you have done your job. And many other disorders actually require full thickness biopsies and sometimes even resections.
Okay, and most of the time in these cases, we get suction rectal biopsies, which is mucosa and submucosa. So if, in the diagnosis of intestinal neuronal dysplasia, do you look at the submucosal ganglion cells, or do you look at the intermyotic nerve plexus?
You look at the submucosal ganglion cells. The criteria are all based on submucosal ganglion cells.
So in these cases of immature ganglion cells, then it becomes a bit difficult to count the ganglion cells that are present.
That's so making a diagnosis of intestinal neuronal dysplasia on biopsy, suction musical biopsies is almost impossible.
Okay.
So you may be very lucky in some case that you have got one submucosal ganglia with too many neurons. You may suggest the diagnosis, but those things can only be made either with the full thickness biopsy or a resection specimen. So honestly, I have never made a diagnosis of intestinal neuronal dysplasia, and me and many others don't even think that this is a real entity.
Okay.
Some people may disagree with that, but some people believe intestinal neuronal dysplasia is just a pattern of or the manifestation of some condition which is not specific.
Yeah, I find that quite challenging, deciding when the changes you see are indeed pathological or secondary changes to chronic constipation. When I have these cases, it's not so clear-cut. That is something, that is constant worry that you're missing something, since it's quite subtle changes.
That's very true.
Okay, I think we've come to an end of the questions. Thank you so much, Prof. We really enjoyed your lecture. I myself have really learned quite a bit, and it has reinforced my knowledge as well in approaching these cases. Thank you for your time. I think it's quite late at night for you.
Thank you so much. Thank you for this opportunity and staying late.
And I hope we can have more such sessions in the future.
Sure. Look forward to that.
Yeah.
Okay.
Thank you, Prof.
Bye.
Okay. Thank you, Prof. Jain, Dr. Pavi, and thank you everyone for attending today's webinar. On behalf of IAPMD and our presenter today, it was a pleasure to have you with us. So this concludes the webinar. Thank you all for attending. We hope you have learned and enjoyed this presentation. Have a great weekend. Bye. Thank you.
Bye-bye.
Bye-bye.